Hello everyone, and welcome to another edition of the Understanding Sports and Exercise Medicine Research Show, the show that brings you the latest research straight from the horse's mouth. I'm your host, Tim Travail from Torrens University in Melbourne. I'm here to support clinicians and early career researchers in the journey through the complex world of health-related research, and ultimately help us to deliver high value and effective care to the people we work with. All right, today it's good to be back after a little hiatus. The birth of my first child a couple of months ago shook things up a little, but it's great to be back. Today we're fortunate to be joined by Mitch Gibbs. Mitch is an exercise scientist and pain consultant, currently a lecturer at Torrens University, Australia, and a PhD candidate through Western Sydney University. Mitch has produced some really interesting work as part of his master's and now in his PhD that we'll get to dive into today. So Mitch, welcome to the podcast.
Thank you very much for having me on, and congrats on the birth of your little one.
Thanks, Mitch. All right, so before we get into the paper, can you just tell the listeners a little bit more about yourself, your current areas of interest and your research journey today?
Yeah, sure. So I started with a Bachelor of Exercise Science at Western Sydney. I kind of got to the end of my degree. I started working as a trainer and a strength and conditioning coach about halfway through. Got like an equivalency kind of accreditation. Got to the end of my degree and I just realized I had more questions than answers. So I dived into the world of research and undertook my Master's by Research, where I looked at kind of the psychosocial elements with, in regard to back pain. That's where I published my first paper all about adherence and buy-in for back pain. Looking at kind of how clinicians should approach the initial session. And then I come to the end of that degree and still had more questions than answers. So my supervisor also kind of persuaded me a little bit to stay on and do a PhD. And so I've completed all my data collection. And as I was kind of saying prior to the show, I'm about 99% done. I'm just refining the last chapter to put it in. So one chapter has been published, and that's the one we're going to kind of talk to today. And the other two, one's in submission and the other one's being prepped. So that's pretty much me. Broadly, research areas are kind of the two sides of back pain. So looking at what we should best do with the patient and then how we can best help practitioners to support patients. So kind of two strands of research, looking at kind of health services research and then also looking at exercise and pain neuroscience education for patients.
Fantastic. Yeah, that's interesting to hear you talk about the trying to delve in deeper and answer some of those questions, and really you just come out with more questions overall, don't you? The deeper you go through this journey, but that's good to hear about. All right, we'll get into the paper today. So the paper was published in Spine, and it's titled "Biomedical Beliefs Explain the Clinical Decisions Made by Exercise-Based Practitioners for People with Chronic Low Back Pain." And these, and that's with yourself, obviously, and Natalie Morrison and Paul Marshall. Are they two of your supervisors at the moment, Mitch, in the PhD?
Yeah, Paul's my primary supervisor. He's an exercise scientist. He's now over at University of Auckland. And Nat is a clinical health psychologist, and she's still at School of Medicine, Western Sydney.
Mm. Now so first question, just around the background context to this. So you mentioned a bit of your own research journey. Is there anything else you just want to talk about in terms of how you got to develop and why you decided that this was the type of paper you wanted to delve into, or this was the type of study?
Yeah, cool question. I think, back pain always kind of perked my research interest, mainly because having Paul as a lecturer and then working as a trainer, I had a lot of people with back pain and I just really didn't know what to do. In terms of a paper such as this, I was kind of looking through the literature when I was designing my PhD, and we were trying to look at what could we do. And I realized that there was virtually no research pertaining to exercise physiologists within the literature whatsoever. There was quite an extensive amount of studies pertaining to physiotherapists, general practitioners, and to some extent, osteopaths and chiropractors about how they approach chronic low back pain, but we really had no evidence-based way of understanding how EPs did it. And then there was a lot of back and forth about, EPs being very well positioned to adopt these contemporary biopsychosocial approaches, but the reality is we had no baseline to measure that against. And I knew I wanted it in the PhD to kind of culminate it in an educational study where I took kind of what we'd found in a clinical RCT and see if we could educate practitioners to improve how they managed pain in the clinic. But I figured that study would be quite redundant without first doing a study to show what's currently happening. So we needed a baseline to improve upon. And that's where the idea for this one really came from.
Okay, yeah, that makes a lot of sense. So we'll just look at the overall study design to start with. So this was a cross-sectional survey design, clear and front and center in the start of the objectives here. So you mentioned that you wanted a baseline to start with to be able to then give you justification and rationale for your later studies. And was the cross-sectional survey, why was that the best for you? Why did you decide on this design?
Because we just wanted to get a snapshot of what was happening. The survey was quite low cost, low resource heavy, and we could recruit a larger number of people than if we were trying to do something a little bit more complex. So it was a little bit easier to grab a snapshot. The reason we contrasted with physiotherapists was, as I said, there is already a decent base of literature looking at physiotherapists and the management of back pain. So if we compared exercise physiologists to physiotherapists, we were able to establish more of a baseline. And then to kind of talk to the other side of research, just to be completely transparent, by including physiotherapists in the study, we were able to aim for a journal such as Spine or a bigger Q1 journal. Whereas if we just went EP, the fear was that a lot of kind of North American journals wouldn't really have an interest in it. So we kind of limited the scope because there was no publication base, whereas with including physios, we could build upon existing literature that little bit more.
That's a nice little tip for, I think, new researchers. You're thinking about that back end publication early on in your study design, and that is so important. There's more and more pressure on all researchers to be going for those Q1 journals. So you've done well there to think about that front and center. So let's get a bit deeper into the methodology then. Can you tell us, so you've got the cross-sectional survey design. Tell us a bit more about how you put that together.
Yeah, so the survey was basically just a compilation of the tools that were already used. So we used the pain attitudes and belief scales for physiotherapists, and I'll talk about why we chose that one in a second. But we chose that to measure attitudes and beliefs. And then we used clinical vignettes to look at clinical decision making. So we could basically see if the individual was leaning towards more of a biomedical or a biopsychosocial dominated orientation to their beliefs and attitudes towards back pain, and then how that manifested in how they treat a patient. The reason we decided to use the PABS PT rather than something like the BBQ, the back beliefs questionnaire, is that it independently measures biopsychosocial and biomedical. And what you'll see in this paper, and then the paper that's currently in submission, which is the educational paper, is this allows us to see the mechanism for change. So for example, again, forward thinking with the educational paper, we really wanted to see, did clinicians change their practice based on a reduction in biomedical beliefs, an increase in biopsychosocial beliefs, or a necessary combination of both? Whereas some of the other tools, they just measure on one continuous scale from more negative to more positive. So using the PABS PT, we were able to look at these two variables independently and see how their weighted contribution to clinical practice.
Okay. And then I'm just thinking, is it worth showing do you think it's worth showing the vignettes for a moment? So they're available as an appendices, aren't they, in your paper for download for people to look at? But just in terms of then putting together the actual vignettes and designing those, were these were vignettes you designed from scratch?
No, these vignettes were used from 2000. Rainville et al. Was the first author to use these, and they've been used. They've popped up in a few of the studies in this area. We used 2 out of the 3. The original paper had 3. The reason we didn't use 3 was the third one talked to a post-surgical patient, and majority of the back pain literature, the first excluding criteria is surgical intervention. So by eliminating that, we made it that little bit more generalizable to the chronic low back pain literature we're kind of dealing with.
Okay, that makes sense. Now, in terms of that part of the methodology, was there anything in hindsight post-publication you would have changed, or are you pretty happy with how that went?
Oh, that's a good question. I think In hindsight, we actually collected. So we also collected their what tools they used in clinical practice, and we realised that we just didn't put it in correctly to get a cohesive data set. So it probably wasted a lot more of the participants' time than necessary for data that we couldn't actually use. So in hindsight, I'd probably change that. I think
when you say patient tools, you're talking about patient-reported outcome measures to see what they were using,
yes.
right? Yeah.
Yeah, but we just had kind of an open-ended response that you could just put in what you used. And then, just from realizing that people, put in tools that we wouldn't have been able to code for, or, the likelihood that they would have, pressed submit and then gone, oh, I actually used that one too. So that was a mistake that in hindsight, I definitely would have changed that. In terms of the actual survey, I was pretty happy with these two survey tools. We spent quite a long time kind of qualifying which one we were going to put in. But in saying that, the other two studies of my PhD, the RCT and the educational study, there's definitely things that, in hindsight, because there's more kind of moving elements in a study like that rather than a cross-sectional survey.
Okay. Now we might move on then towards the sort of the plan for your statistical analysis. Is that easier to, are you happy to talk about it now, or do you want to go and talk about that as we get to the results? What's easier?
We can go through that now. Yeah.
Yeah. Okay. Tell us the plan for the stats part.
Yeah. So basically, first and foremost, we just wanted to see if there was any differences between the AEPs and the physios. So what actually, were there any differences between these two groups of practitioners, these two fields of practice? So we just used an analysis of variance to see if there was any difference. And we found there was no AEPs were higher on the biomedical scale, but there was no differences in the biopsychosocial. But from there, that didn't really tell us what we wanted to know. What we wanted to know was, did biomedical or biopsychosocial beliefs respectively contribute to clinical decision-making? So we needed to use regression analysis to see, did they explain the vignette responses? So we did a stepwise regression analysis for each vignette response, building in the biomedical response, biopsychosocial response, and the profession. And that's where we found that biomedical beliefs explained the clinical decision-making, not the biopsychosocial. And then finally, what we did was we used a reference from a paper in 2008, Bishop et al. 2008, which we looked at a subgrouping analysis. So we looked at professionals that exceeded the upper limit and lower limit, respectively, for the two scales. So for example, if someone had a biomedical scale score that was above the standard deviation and a biopsychosocial score that was below, they were kind of high-end biomedical. And then if another professional had a biopsychosocial score that was above the standard deviation and a biomedical that was below, they were high-end biopsychosocial. And then we built in a regression analysis around kind of the outlying professionals to see, what happened at these extreme endpoints. Because, we know we run into these practitioners that are, way too far on the spectrum, of that kind of biomedical or biopsychosocial, so to speak. And we wanted to know, well, what really happens with clinical decision-making at those extremes?
Okay. And we'll jump down then into the demographics and the recruitment side of things. How did you find, just to touch on the recruitment first?
Yeah, so the physio recruitment, I have to take my hat off to Simon Summers and his group, which were literally a building away at Western while I was there, but we didn't actually collaborate on any research. So they used a method that I kind of nicked from one of their papers, which was we went on to the Australian Physio Association website and it went into the Find My Physio section and just took all the emails and just sent the survey to all the physios with the information sheet and things such as that. It was all anonymous. So they were able to just fill it out without providing any details and things such as that. So that took care of the physios. The AEPs was a little bit harder. I was quite happy. ESSA provides, so Exercise Sports Science Australia, they promoted it for us. I applied for an in-kind support. So it was promoted in a few of their magazines and newsletters and emails and websites and things such as that. So that helped with the EP recruitment. But the EP was a lot more legwork Luckily, I kind of am in that industry, so I was able to get friends of friends to send emails to all their colleagues. But yeah, the recruitment's extended. It's in here somewhere. I think it was about 6 months it took. But yeah, as you know, any researchers listening will know, recruitment's always probably the most difficult part of a human research trial.
Yeah, absolutely. And so there were, and the 75 each, I saw that you obviously total recruitment. Did you cap that at 75? Was that the target number you were looking for?
Yeah, I think we were looking for the power calculation is somewhere. We were looking for less than that. So I think we were powered at, it was maybe 60 or so a group. And then I think we just had an influx one day and one group popped up to 75. So we kind of went, well, we may as well just get the other group up to 75 and then call it an even 150.
Yeah.
My supervisor has a thing with even numbers. So
right, okay. That wasn't some magical power calculation. It was just a nice round number.
Pretty much.
Fair enough. What have we got? Top of the third page there, we've got your we've just got the practitioner demographics. Anything surprising you about this, or this is sort of as you expected in terms of you've got levels of education and sort of years of experience in practice? Anything in there to mention or talk about to the listeners?
There was nothing that really jumped out as surprising. I think, where is it? The years of practice was significantly different between groups, but with EP being a younger profession, we kind of expected that. I think the only surprising was the confidence factor. The confidence was probably a lot higher than I expected, but that was probably just my own bias that, you know, I've kind of got that researcher's touch of imposter syndrome. And I think I saw that confidence a little bit higher, and I kind of sat there and went, "Oh well, you know."
And how was that? How was the confidence measured?
It was a Likert scale, so it was from not confident to completely confident. I think it was 1 through or 0 through 6, and as you can see, both groups were pretty much bang on 5.
Yeah, and just give us a bit of context behind that confidence. So it was a confidence to apply sort of evidence-based treatment practices to these demographics, or?
Yeah, it was confidence to treat back pain. We left it a little bit more ambiguous.
Okay. Yeah.
Just more general. It's just confidence to, you know, treat an individual with chronic low back pain.
Okay. Yeah, I agree that is pretty high in the confidence across the board. I wonder whether their patients will be as confident as they are in their practices.
Yeah, that's one thing actually, you know, coming back, that's triggered a thought to, you know, something I would have changed. It would have been phenomenal to do something where we surveyed patients as well. But to build in the anonymity aspect, it just would have been, I wasn't able to think of a way that we could do that and allow practitioners to engage in this survey with complete anonymity.
Yeah.
I think that was one of the reasons we got the numbers we got in the time we did, was because, you know, it was completely anonymous. There was in no way, shape or form anywhere to put your name. Yeah. There was a separate website that you could lodge your email if you wanted results, and there was no way to link those two data sets. Yeah. So I think it would have been great to survey patients of those practitioners as well, but being a more kind of, you know, invasive, I guess, for want of a better term, research plan, it would have been a lot more complicated to get recruitment numbers. But that's just my guess. I could be wrong there.
No, I'm sure you're not wrong. That's the pragmatics of research, isn't it? With sometimes you need to work out how you're going to get those responses, and whatever we do, I think in research, if people are putting their name somewhere in the form, then there's a sort of there is some questions raised with that, and perhaps harder to get the amount of results that you did. So understandable.
And I think just quickly too, I think just the accuracy of reporting too. If someone's attaching their name to it, you know, there's that kind of Hawthorne effect question. Are they really going to answer this truly, or are they going to answer what they think the researcher wants to see them answer as well?
Yeah. Okay. And so you mentioned that recruitment's obviously always challenging. Well, overall, in the methodology, what was the hardest part of this study for you?
I think the hardest part was probably the legwork of the recruitment, sending 600 individual emails to physiotherapists, and running around trying to get AEPs.
Yeah.
Yeah, I think that would have definitely been the hardest part for this.
Yeah. And you say you didn't have too much challenges with sort of pulling the statistics together in the end. That sort of worked pretty well from the data you were bringing in.
Yeah, the statistics, weren't too difficult in this paper. It's just, the ANOVA and then the stepwise regression. And we were kind of powered to do both of those calculations. So that works pretty seamlessly once the data set was complete.
Yeah. And what program did you use to run those through?
I use SPSS.
SPSS. Okay. Yeah.
Yeah.
All right. Was SPSS something you had familiarity with in your previous master's of research work, or is that something that you kind of learned those skills and built those up as you were?
Familiarity. So in my master's of research, Paul was my only supervisor. Then Nat came along to the PhD. Paul's a big fan of just kind of throwing you in the deep end and watching you swim or sink. And so I think my first paper was an ANCOVA, and then the other chapter in the thesis was multiple mediation and multiple moderated mediation through a downloaded and imported macro to SPSS. And Paul just kind of gave me one journal article citation and just went, figure it out. You've got 2 weeks. So
okay.
Yeah,
you obviously came out swimming.
Yeah. Pretty much had to. So yeah, I got pretty familiar with SPSS pretty quick from that experience. And if Paul ever listens to this, he'll probably be laughing. He's a bit sadistic like that.
All right. Well, I might need to hit you up a bit down the track when I get to using some of the SPSS.
It's definitely a struggle initially to wrap your head around. I didn't find it easy from day one. Like, I don't want to sit here sounding like I just picked it up. It was, long sleepless nights trying to figure out how that program works initially.
Yeah. But you got there. And you feel confident with it now?
Yeah.
Okay, excellent. All right, let's get a bit into the results then. So where's the key area? Is this the best? This is probably the best table at the top of this page here to go through the results.
Yep.
Mitch. All right, so we're just looking at table 2 of the paper, which is the group and between group differences here. So do you just want to take us through this table?
Yeah, of course. So the interesting one initially that jumps out is there was a between group difference in the biomedical subscale, but not biopsychosocial. Mm-hmm. And this is not what we wanted to see, but what we wanted to tease out. This is again why we chose that PAB scale, so that we could measure these two concepts independently rather than just looking at a continual kind of dichotomy. Whereas the other one that jumped out was pathology in the second vignette. We can see the p-value down there. Again, we really had no idea what we were going to see in the vignette responses and the clinical decision making, because there was no evidence base to inform that. We kind of knew what to expect from physio, but we didn't know what to expect from AEP. Yeah. So when we look at the pathology, basically I think I wrote into the discussion my kind of proposed potential reason for that was physios being trained in more diagnostic measures and things such as that, whereas AEPs don't really have that scope of practice. So that could potentially explain a difference in a pathology item, whereas there was no between group differences between any of the other items. And if you scroll down to table 3, I think that'll be the regressions. Yeah, so we've got the regressions here in table 3. And you can see, so this is a stepwise regression. So this is basically including variables as they enter. It's not just entering all variables and looking at the model. We're looking at including variables at the time. So as you can see, biomedical beliefs just wins pretty much throughout the whole thing, with the exception, or not the exception, but the addition, sorry, in the first vignette pathology, there's also biopsychosocial, which adds an extra couple of % to its predictive kind of power of the decision making. So when we look at this table, what we're really seeing is that the biomedical beliefs are explaining the clinical decision making across the board for both groups. Mm-hmm. So profession was built in as a variable. So if profession emerged as a between group difference, it would have came out within this regression analysis. So interestingly, what we saw contrasting table 2 and table 3 was the biomedical beliefs were higher for AEPs. There was a higher biomedical beliefs for that group compared to physiotherapists, but profession didn't emerge within the regression. So what this tells us is that biomedical beliefs independent of profession are what's explaining clinical decision making. So it doesn't matter what profession an individual practices in, it's their belief structure that's going to dictate their treatment, not their actual field or professional discipline.
And that aligned with what you were hypothesizing? Did you expect that those type of findings to come up?
We really had no idea
Yep.
because we didn't have any research on AEPs, so we had no idea what to expect for the AEPs. So the whole kind of question around profession in this domain had never really been asked before. So we really didn't know what to expect there. It was more exploratory, as I'd kind of word it.
Yeah, no, that's great.
What that led to, though, I might just kind of bring it up there before we go on. So that third study that I kind of mentioned earlier, which was the educational study, that informed that in terms of we then hypothesized that a reduction in biomedical beliefs independent of a change of biopsychosocial beliefs would lead to improved clinical decision making. So this study, I'd call this more hypothesis generating than hypothesis kind of testing.
Yeah. Okay. And that's pretty common early on in sort of the structures of PhDs, isn't it? Like we're trying to generate that hypothesis to give you the argument to go on to whatever your later studies are. So yeah, that makes a lot of sense. All right. Was there anything else in the discussion that's worth pulling out, or perhaps we can sort of show the highlights of the conclusion here? And I think you've probably talked to some of these, but is there anything else that was worth mentioning?
Not off the top of my head. I think the big kind of finding was more what I just kind of spoke to there, which was it was the belief structure rather than the profession. So, you know, a lot of these kind of potential arguments, for want of a better term, about what profession might approach things in what way. You know, we don't really have evidence to show that a profession comes with an inherent approach. It's more the beliefs of the individual practitioner that have the ability to influence what clinical decisions are made.
Okay, and that gives us a good summary, Mitch. And then what do you hope that clinicians then would have a look at this paper, and what would they be able to take out? And perhaps I can say there's definitely should be some self-reflection for most practitioners here about my own personal belief structures and how that might fit in with my treatment decisions. What would you like to tell practitioners about what they should be able to take away from this paper?
Yeah, I think to kind of put a clear message, I think it's hard to take a message from this paper in isolation because, as I said, it was hypothesis generating, and I don't want to oversell the kind of the meaningfulness of this paper in any way. A lot of this paper is only really solidly backed, for want of a better term, by the research that's already come. You look at kind of Ben Darlow's research and his group, and Peter O'Sullivan and some of the stuff that has been done there as well. The ability of the practitioners, biases and beliefs to influence the patient's understanding. And I think this study just kind of adds layers to that argument and that understanding that, our patients will adopt our beliefs and will adopt our biases, and our treatment approaches will be influenced heavily in our clinical decision-making by our biases and by our belief structures. So it's more about acknowledging what they are and addressing what they are would kind of be the take homes, I guess, from this kind of line of research.
That's fair enough. And if we flip that question on its head and talk to patients now, and I know you're not wanting to oversell it, but what would you like a person in pain who's perhaps read this paper to be able to take away from it?
Yeah. If a lay person in pain read this paper from the Spine Journal, I'd be very happy.
I'd be impressed, but
yeah, I'd be very happy.
If they listen to this podcast and they were thinking, well, what does that mean for me as a person in pain?
Yeah, no, and I think that's great. And, that's why I'm a big fan of podcasts, and, I try and do dissemination stuff for that exact reason. No, I think what I would take away is, or kind of give the message to patients there is, in a way, it's okay to question a practitioner's argument if you've heard different and if you've been told different. And, the other thing too is the amount of times I've had patients come to me and, they've kind of expected a treatment because they've had it before or been told it before. And then, my first question is, well, did it work? And, their answer is, well, no. It's okay, well, why are you expecting that? And it's just about being, critical thinking isn't just something that happens in research and kind of in the health profession. It can be for anyone. And I think it would more be just acknowledging, where is your practitioner treating kind of their bias coming from, I guess, in a way.
Mm-hmm. Excellent. And so can you just summarize for us where this has led you to? So there's quite a lot of lessons out of that paper in terms of that hypothesis generation. Can you just talk to us, you've got a couple of those papers which are about to come out, but just tell us where this paper really, how did it support you as a PhD student to then really springboard you into those next studies?
Yeah, I think it gave the ability, so that hypothesis generation kind of gave the ability to test that generated hypothesis. I think it was for me, it was more of an area of passion. So I ran the randomized control trial as well, which again, quite passionate about. But to me, I've always seen the kind of the practitioner's attitude and belief as the overarching, I'll use problem because I can't think of a better word, but, we can have these evidence-based recommendations. We can have, if we look at clinical treatment guidelines, encompassing biopsychosocial management and current best practice and all these things. The reality is if the practitioner and at the kind of clinical level isn't engaging with these things, then ultimately that patient doesn't get that treatment. And to me, that's always been kind of the blockade of dissemination of best practice is kind of the practitioner's bias. And so I think this paper kind of really showed me that there is a bias and that bias does affect treatment. I think I wrote it into the discussion somewhere. It was along the lines of, I'm trying to think of the words. I've just lost it, sorry.
That's right.
I literally just read it a moment ago. Sorry, I do apologize.
Yep.
But yeah, it's basically just kind of saying that how we approach things is affected by our biases, and it's more about acknowledging those biases and having kind of the patient at the forefront and that patient-centered practice. And that's where this study really has led me to that kind of focus is ultimately I want this knowledge and this dissemination to help the people in pain. And if, kind of those biomedical beliefs and orientations are going to present that, that blockade to that best practice research coming down and funneling down to the people in pain, then that's what's led me into this research area.
Yeah.
I hope that answers the question.
It does. So Mitch, just to sort of wrap things up, how can people contact you or follow your research?
Yeah, so I've got an Instagram account, which is at rethink.mvmnt, Rethink Movement, which is myself and one of my colleagues who's an EP as well.
Yep.
I've got a Twitter page, which I think is just at Mitch T. Gibbs. I'm pretty poor with social media at sometimes. And then just the usual stuff, ResearchGate and things such as that.
Yeah. I think a quick Google, your name comes up pretty easily. So I'm sure people will be able to find your research there. All right. Anything else you'd like to add? Otherwise, we can probably wrap things up about there.
No, just thank you very much for having me on and the opportunity to chat about the paper. It's been quite fun.
Pleasure. Thanks very much, Mitch. And we'll look forward to these follow-up papers available soon.
Thank you.